Good afternoon, dear colleagues, ladies and gentlemen. I do apologize for not being with you today, but I was unable to make it. I am sorry. Anyway, I'm happy to share with you our experience in dealing with atypical and severe forms of chikungunya. What I'm going to do today with you is to report the analysis we performed on the cases of severe and atypical forms that were admitted to the University Hospital Medical Center of Guadeloupe during the outbreak of chikungunya last year. My name is Bruno Hoen. I am the head of the Department of Infectious Disease in the University Hospital Medical Center of Guadeloupe. And I would like first to acknowledge all the people who worked with me struggling this epidemics, and especially the members of my team at the clinical unit and here on the slide, and with a special thank to Amélie Rollet, who collected all the information on severe forms I will talk about today, and also my team at the investigation center, as well as my partners in the virology lab, in the epidemiology unit, Sylvie Cassadou and Mathilde Melin, and my friend and colleague, infectious disease specialist in Martinique. Let me start with a brief reminder on what was the epidemics in Guadeloupe. The epidemics terminated in December 2014. At that time, based on an estimation by the network of the Sentinel doctors in the island, it was estimated that 80,000 people had contracted the disease, with a peak of the outbreak in the summer, with a little more than 6,000 cases per week at this peaking week. It now is, although we do not have the results of serosurvey, it now is estimated that about twice as high, as many patients have been infected with chikungunya. That is around 160,000 people in Guadeloupe. A minority of them have been admitted to hospital. In Guadeloupe, it was mainly children that were admitted to hospital, while in Basse-Terre it was mainly adults. When looking at the number of cases that were admitted to hospital, more than 600 cases were recorded, distributed at the end of the year in 126 severe cases and 441 non-severe cases. This is the classification performed by the unit of epidemiology, and I will give you a new insight in this distribution for the Seoul University Medical Center in Guadeloupe. It has been recorded that there were 21 people who died after being admitted to hospital with a potential diagnosis of chikungunya, but also a little more than 50 people who died at home while they were coping with a chikungunya infection. When we pooled the information on the epidemiology of the two outbreaks that occurred in Guadeloupe and Martinique, we obtained, and this graph was constructed by my friend and colleague André Cavier in Martinique. You can see that about 300,000 cases were recorded on the two islands, with a peak peak epidemics in summer 2014. When comparing the outbreak that occurred in the island of La Réunion in 2005-2006 and the epidemics that occurred in the Caribbean, and using the pooled data that I showed you on the previous graph from Martinique and Guadeloupe, we can say that there were more similarities than differences between the two outbreaks. The factor was not the same. It was Aedes aegypti in the Caribbean, when it was Aedes albopictus in the island of Réunion. But also at the peak of the epidemics, the number of weekly cases was lower in the Caribbean than in the island of the Réunion, as you can see on this line of the slide. But the percentages of severe forms and the cases that were admitted to hospital, there were not significant differences between the two outbreaks. Well, now I will present you the analysis we performed on all the cases that were admitted to our hospital with a PCR confirmed diagnosis of chikungunya, since all these patients had their records analyzed and abstracted using a standardized CRF. After doing this, we assigned each case to one of the following three categories: either common uncomplicated form or atypical form that was defined by at least one unusual organ system involvement, and finally severe forms that were defined as at least one organ system failure associated or not with admission to intensive care unit. This is the distribution of the 525 cases of patients with chikungunya that were admitted to hospital during the year 2014 in the University Hospital of Guadeloupe. As you can see, the most important group was the pediatric cases that accounted for more than half of the whole cases, with almost 300 cases. There were also a little more than 100 cases that occurred in pregnant women and were managed in the gynops department. What I'm going to present to you today is the analysis we performed on the 119 cases of adult cases that were admitted to hospital during the outbreak. Using the definitions I showed you just before, we classified the cases in 48 common usual forms, 19 atypical forms, and 38 severe forms. There are 14 cases for which we are still unable to classify the cases because of missing information. In this table, the three clinical syndromes are presented and compared. What you can see is that patients who had severe forms were significantly younger than patients with common or atypical forms of the disease. There were no differences in terms of sex ratio between the three groups. Regarding underlying conditions and comorbidities, you can see here for the three most frequent underlying conditions that were recorded, that there were no significant differences between the two groups. However, there was a trend towards less frequent comorbidities in those patients who had severe forms of the disease. And when we constructed a composite variable that combined all comorbidities that were recorded. There was a significantly lower rate of comorbidities in patients who presented with severe forms of the disease. Regarding laboratory parameters, serum CRP was higher, but not significantly so, in patients with severe forms. Likewise, the white blood cell count showed higher values for patients with severe forms. There were no significant differences regarding the platelet number, which was nevertheless a little lower in patients with severe forms. Obviously, there were differences in the outcome, with a high number of deaths, 11 over 38 in patients with severe forms, while no death in patients admitted to hospital with common forms, although they had more comorbidities, and only one death in the patients who presented with atypical forms, but the death that occurred in these patients was not related to chikungunya. Another important information that I would like to show you is that among the 38 patients who had severe form of chikungunya, 27, which is 2/3 of them, presented with a severe sepsis syndrome or a septic shock. We used, for doing this analysis, the usual definitions for sepsis, severe sepsis and septic shock. And all these patients started the disease with initial clinical manifestations that were typical of chikungunya. They were, in a second step, admitted to hospital for unusual severity, and all of them had positive PCR, chikungunya PCR. And in none of them, another cause for sepsis could be identified, with all blood cultures negative, urine culture negative, and chest and abdomen CT scan non-contributive, for another explanation for this severe sepsis syndrome or septic shock. These are the characteristics of, the main characteristics of the 27 patients with chick-induced severe sepsis syndrome and septic shock. There were 16 males and 11 females with a median age of 67 years. These are the underlying conditions that were observed in these patients, but again, the proportion of the overall comorbidities were lower in those patients with severe forms of chikungunya as compared to patients with conventional or atypical forms. Interestingly, most of them had significant laboratory abnormalities. These are the main parameters that were looked at. CRP, white blood cell count, serum creatinine level, aminotransferase, LDH, and creatine kinase. And you can see that abnormalities could be relatively important. But as you can see here, the median value is for almost all these parameters, but especially the chemistry parameters were higher than the median value, which implies that some patients have very high value that skewed the distribution and gave this relatively high levels for the mean values, especially for CK or LDH or AST. But anyway, as you can see, most of these patients had significant abnormalities on these parameters. When an alternative diagnosis was searched for in these patients, this was done in 8 patients for leptospirosis. Diagnosis was always negative. This was also done for dengue fever in 15 patients, and in all the patients in which the tests were performed, the results were negative. The outcome is impressive, with 9 deaths, accounting for a mortality rate of 33%. Just to illustrate with one case report what this syndrome looks like, I would like to present this case report, which is based on a patient whose management I was involved in. It was an 85-year-old man, still professionally active, was a shopkeeper, and very healthy. He had no significant prior medical history, was treated for hypertension, and was doing really well. He starts with his disease on September 26th with the abrupt onset of an influenza-like syndrome. He will seek for medical aid only 4 days later, and when he comes to his doctor, the diagnosis of chikungunya is considered as very likely, but because of the age of the patient and because he had high serum CRP levels, he was given ceftriaxone. The next day, on October the 1st, he was admitted to our hospital in our department. Once again, we considered that the diagnosis of chikungunya was very likely, with high-grade, acute onset, spiking fever, and swollen ankles and wrists. We sampled blood for chikungunya PCR and repeat blood cultures, and decided to carry on ceftriaxone for the same reasons as those who made the prior doctor start ceftriaxone the day before. During the night following his admission, he developed very abruptly a septic shock. He was transferred to the ICU, where he died within 4 hours. These are the results of the diagnostic test that we received post-mortem. All blood cultures had remained negative. The urine culture was negative too, and I mean the urine cultures that had been performed before ceftriaxone was started, and the chikungunya PCR was confirmed to be positive. And this case illustrates most of the other cases that were gathered under this label of severe sepsis syndrome due to chikungunya. So just to summarize on this issue of severe forms, based on our experience of patients that have been admitted to hospital during the outbreak, patients with common uncomplicated presentation of chikungunya who were admitted to hospital were admitted mostly because of underlying conditions and comorbidities that were regarded as at risk for decompensation. But more interestingly, more than half of severe forms of chikungunya were related to a severe sepsis, septic shock syndrome, which most often developed in patients without specific comorbidities. To our knowledge, such a syndrome had not been clearly described so far, especially during the outbreak that occurred in the Réunion Island. And to finish, I would like to highlight an atypical form of will say, complication of chikungunya we observed during the epidemic, which was the Guillain-Barré syndrome. We observed these complications both in Martinique and Guadeloupe, and we decided to collect the information from both islands. And this is the summary of the cases we analyzed for this collection. The case definition we use is the following. Patients had typical signs and symptoms of Guillain-Barré, including clinical signs, CSF examination, and electromyographic examination. All of them had a very recent clinical history of chikungunya, and in all of them, at the time of the diagnosis of Guillain-Barré, they either had a positive IgM serology or a positive PCR. And in none of them, another etiology was identified. So in total, we recorded 13 cases of Guillain-Barré in French West Indies, 6 in Guadeloupe, 7 in Martinique. There were 9 males, 4 females, with a median age of 62 years, ranging from 48 to 80 years. The median time between acute chikungunya onset and the development of Guillain-Barré syndrome was 8 days, very short, ranging from 1 to 22 days. 2 of these 13 patients had a Miller-Fisher syndrome. 6 patients were admitted to the ICU and 5 received mechanical ventilation. All but 1 patient received intravenous immunoglobulins, which was followed by a significant improvement in most of them, 10 of the 12 treated patients. Interestingly, this is why I showed you this slide. The incidence of Guillain-Barré in the population who developed Chik during the outbreak of chikungunya last year could be calculated to be around 4.3 per 100,000 population, which is higher than the overall annual incidence of Guillain-Barré in France, which ranges, depending on the years, between 0.5 to 4 cases per 100,000. So this is why I wanted to show you this information. Maybe you had the opportunity to diagnose Guillain-Barré syndrome in patients with chikungunya, but we think that this case collection demonstrates that Guillain-Barré syndrome is a frequent complication of chikungunya infection. Well, that's it. I will wrap up and thanking you for your attention. And once again, I'm sorry not being with you, so that I will not be able to take any questions. But I wish you a very successful meeting. Goodbye.